You can start now, ma'am. Your live.
Okay, please start, Teja. Yeah.
Good morning, everyone. Happy Diwali. Thank you, Hicks team, for giving me an opportunity to talk. Today, I'm going to talk on paraquat poisoning. I'll be talking under these headings: introduction and pharmacology, kinetics and clinical feature, laboratory evaluation, management, and extracorporeal therapies about paraquat toxicity. So, in introduction, the paraquat ingestion is one of the most leading cause of fatal pesticide poisoning in many countries, especially in the developing countries. It's because of the inexpensive and the easily available pesticide. It is a rapidly acting non-selective herbicide, relatively very inexpensive. There is no restriction in its sale. It has been discovered in 1950 and found its way in agriculture use by 1962. The clinical course of paraquat poisoning is very long. It prolongs weeks together, and there is no antidote for this toxicity. Usually, the fatality is 70% in severe toxicity. Coming to the pharmacology, the most common route of poisoning is ingestion, followed by exposure while with the skin and inhalational routes. The most commonly used percentage is more than 20%. Usually, 24% is available, highest concentration of the paraquat. Paraquat and diquat are mostly available, are classified in dipyryl compounds, and most of them the paraquat and diquat poisoning is almost similar in presentation, except that the diquat has do not have a long-term sequelae. Pathophysiology, when it comes to the most common targeted organ, is lung and kidney because of its high blood flow. It causes redox cycle. Usually, the paraquat ion which enters into the body will cause a redox cycle where NADPH is cyclically reduced and releases a free radical formation. These free radicals are the oxygen free radical. Because of the superoxidase mutase, it will bind with the H ions and releases the oxide ion. And these all flow will gives you oxygen free radicals. These oxygen free radicals will cause a glutathione oxidation, and which causes structural and enzymatic protein abnormalities and NADPH depletion. It also causes lipid free radicals. These lipid free radicals will disrupt the lipid membrane, and it causes degeneration of most of the organelles present in the cell. So these causes a cell death and causes a multi-organ injury. So, pathophysiology of it is because of the absorption. It concentrate mainly in very high blood flow and oxygen tension areas where there is energy requirements are very high, particularly lungs, heart, kidney, and liver. Brain is you uncommonly affected in this because the blood-brain barrier is not crossed by the paraquat. That is the reason most of the patients who had the paraquat toxicity will not present with altered sensorium. If at all, if they have presented with altered sensorium, we need to see for the other toxicities also. Co-ingestion with other pesticides also has to be seen. So in moderate levels, initially it will cause us lung injury. It will progress over the weeks to the pulmonary fibrosis. It's because of the rapid and excessive proliferation and differentiation of fibroblasts, and the pulmonary architecture is lost here. And in kidney, it causes more of a vacuolation of a proximal cell tubule, causing ATN. It also causes diarrhea, which causes hypovolemia and leading to AKI. Hepatocellular injury occurs secondary to mitochondrial damage and endoplasmic reticulum also causes degranulations. When it comes to kinetics, it is very polar and corrosive substance. It is not absorbed in the intact skin or the droplets because it cannot cross the lipid membrane. It has to be absorbed through the stomach. But even in the stomach also, it will cause an incomplete absorption. And usually the absorbed paraquat will have a very high concentration to get absorbed. To reach the maximum tissue levels, it takes 6 hours, and elimination is usually within 24 hours in a very minor poisoning, but it will be delayed because of the uh, ATN caused by the kidneys in a severe poisoning, and it will delay the, so there won't be elimination of the paraquat. Paraquat will not get metabolized. It will eliminate, has same paraquat only, and the elimination half life is more than 400 hours. Sorry, 200 hours. So the clinical manifestation, if we see into, mostly it is a history based. History, the clinician has to emphasize on the aspects of history in paraquat poison suspicion. That is, how much ml has been taken, at what time has been taken, and how much strength and dose of it has to be taken through the history. Most of the time the comorbidities and patient age matters, because a patient with already chronic kidney disease and age of more than 50 years will have very worse outcomes. Time of ingestion is very important to initiate our extracorporeal therapies. Oral and GI symptoms are very common. If the patient has tachycardia, hypotension, that means that the patient has a systemic toxicity, and usually it leads to the fatal outcomes. So to divide these severity of paraquat poisoning, we have this mild, moderate, and fulminant type. In mild variety, that is subacute poisoning, usually less than 20 mg of body weight of paraquat has been taken. Usually they'll be asymptomatic, and very mild symptoms like oral ulceration, pain during swallowing is observed, and minimal pulmonary and renal involvement may be seen within 24 hours of the ingestion time. Usually, we can expect a complete recovery in such patients. Moderate intake patients will have usually taken 20 to 40 mg per kg body weight of the poison, and they'll have immediate presentation, will be vomiting, and hours later it will cause diarrhea, abdominal pain, and oral ulcerations. Vomitings usually in during vomiting period, when the patient has come, if we take an MPG, usually they'll have an alkalemia. Once the diarrhea is set in, hypovolemia and AKI has set in, they will go into acidosis part. This is usually within hours of the presentation. But when it comes to days or more than 24 hours, they'll have a renal failure, hepatic impairment, hypotension, and tachycardia. If it is weeks after that, they will go into the pulmonary fibrosis. Survival is possible, but usually, if we take an aggressive measurements with the extracorporeal and aggressive supportive care, but usually expected death within 2 to 3 weeks because of the lung deterioration mostly. Fluminant type of poisoning, here we see when the poison is more, intake is more than 40 mg per kg body weight, immediately they'll present with the vomitings. Within 6 hours of the presentation, they'll have diarrhea, abdominal pain, and AKA presentation will be there. Ulceration, pancreatitis, myocarditis, and refractory hypotension and coma can be. Survival is very difficult in such patients in spite of supportive and extracorporeal therapies. Death is expected within 1 to 4 days. The death is usually because of the multi-organ failure. So let us see with the laboratory analysis how we do it. Usually the qualitative confirmation is by urine spot test. It is with the alkali and sodium thioethanate. Here, a negative urine test should be repeated after 6 hours of post ingestion. If we know the timings when the patient has taken and there are no symptoms, even negative at the time of arrival to the ER, has a negative urine test, we have to repeat post 6 hours to reconfirm that there is no serious sequelae. Urine and gastric aspirate has to be taken, and usually it based on the reduction of the paraquat cation to the blue radical ion in the presence of alkali and sodium thioethanate. It is the principle of it. The paraquat ion will change to blue color when there is a alkali medium and diethanate present in the urine or the sample. So first we need to add alkali, that is sodium hydrochloride or sodium bicarbonate. Usually it is added to 10 ml of urine or any of the sample. You have to make the pH above 7 prior to adding to the sodium diethionate. Then a spatula full of sodium diethionate has to be added to this alkalized urine or a gastric aspirate, and you have to mix it gently. So at that point of time, you can see a color change from blue to blue to green color, depending upon the concentration of paraquat, and it will confirm your test. The higher the paraquat levels, it might change to black color also. So at that moment of time, you need to dilute the sample before performing the urine diathanate test. And it is used as a semi-quantitative because depending upon the color, you can estimate the concentration of the paraquat in the urine. Usually less than 2 micrograms per ml will cause, it is almost similar to that of the uh, normal urine color. So it will help you out in semi-quantitative analysis. So for quantitative analysis, usually we take the plasma. Here, the plasma has to be analyzed rather than serum because serum paraquat concentration is approximately 2 to 3 times lower than that of the plasma. So, always use a plasma. And serum, if at all there is non availability of plasma, or already there is a serum, then when you are interpreting the results, you have to be very careful because the serum concentration is usually less than that of the plasma. The quantitative measurement in the plasma gives an indication of the severity and prognosis. The sample usually has to be taken after 4 hours of post ingestion because it takes a minimum time to reach the blood levels 4 hours. So you have to take a sample 4 hours before ingestion, and it always should be stored in the plastic, not in the glass tubes, because it will give a false negative results. Usually there are normograms, paraquat poisoning normograms. One is used as SIPP, which is usually used, where it is mandatory to know the time of ingestion because to estimate the paraquat levels and estimate the prognosis of the patient, the time of ingestion and paraquat levels are important. The paraquat levels, it is a few of the nomograms used. One is Proudfoot line, Schreman's extension, and Hong. These one of the nomograms which we use to estimate the prognosis. If the concentration of the paraquat is above that of the respective lines, then the prognosis is usually poor. So, renal function tests, liver function tests, serum electrolytes, and complete blood pictures have to be done daily. If the patient is very sick, we need to do every 6th hourly to 12th hourly, depending upon the condition of the patient. Further testing, further lab investigations have to be done based on the clinical situation. Radiographs usually useful in a patients who have come with the tachypnea to see whether it is secondary to the alveolitis or because of the aspiration, as there is a ongoing vomitings. Usually, if you see a bilateral infiltrates, then you can think that it's because of the lung injury caused by the paraquat toxicity, usually alveolitis. And as the days goes on, in the weeks, the patient will end up with a pulmonary fibrosis. The rare complication is pneumomediastinum or pneumothorax. If at all pneumomediastinum is present, that means that the patient prognosis is very bad. Mortality is very high. Serum amylase and lipase will indicate acute uh, toxin-induced paraquat-induced pancreatitis. Usually, the pulmonary lung injury is progressive. Usually, takes more than several weeks to recover. Whereas in AKI, if you give a good supportive care with the dialysis and everything, they resolves over the weeks. So, in case of difficulty in diagnosis, when you don't know what the poison has been taken, when there is an unknown agrochemical ingestion, first thing we need to see what were the symptoms of presentation. If the presentation has only oral GI burns and without systemic toxicity, then paraquat is very unlikely because most of the corrosive substance will not cause systemic toxicity. But if the GI symptoms, that is, oropharyngeal burns, are associated with the systemic toxicity, then the chances of paraquat poisoning are very likely. And most of the pesticides will not cause oropharyngeal burns; they cause systemic toxicity. So, to differentiate between a corrosive poisoning, other pesticide poisoning from paraquat, it should be a combination of several combination of severe oropharyngeal burns with a systemic toxicity. And if in doubt, always do a urine diatherin test to confirm your diagnosis. For management, it depends upon the amount that has been taken and the time lapsed from the exposure to the arrival to the ER. None of the current treatments have proven to be effective, especially in a severe poisoning cases, and usually the prognosis is poor in spite of multimodal therapies. Symptoms and signs usually manifest from 6 to 12 hours. Within 12 hours, some of the manifestations has to be there, at least the ulceration. Ulceration usually take 12 hours minimum. Urine diathermy test beyond 6 hours post ingestion. If it is negative, and patient is also clinically stable, asymptomatic, then he's cleared for discharge, as it is indicates the very minimal poisoning or no poisoning. So first, early treatment. Once the patient arrived to the hospital, always ABC is the criteria. First, secure airway breathing circulation depending upon the clinical circumstances. And GI decontamination has to be done. It only limits further systemic exposure. So, activated charcoal has to be given. It is given at 50 to 100 grams for adult, and for the children, 0.5 to 1 gram per kg. Uh, in children. Uh, in absence of activated charcoal, you can use fuller's earth. Fuller's earth is a multhani matti. It is 15% suspension we can use, or bentothionate, which is given at 100 to 150 grams in an adult. You should always give this charcoal along with the gastric lavage. Gastric lavage alone has no role and should be avoided. Endless gastric lavage is of no role. You have to give with the charcoal. So early management, first IV fluids, because kidney is a major route of excretion of paraquat. So therefore, the kidney function has to maintain, because most of the AKI is secondary to ATN plus hypovolemia leading to AKI. So we need to do a fluid replacement, and closely monitoring and optimum functioning of urine output has to be taken uh, in these patients. Analgesics, aggressive analgesia has to be given, since this patient will have severe pain from oral and esophageal and abdominal corrosive injury. Mouth care has to be taken in case of ulceration and inflammation. Do not use chlorhexidine, as it will cause more pain. Betadine mouthwashes would be a better in these cases where you require a oral care. But patients should be kept nil from mouth if there is a suspicion of oropharyngeal injury. Always keep in early insertion of NG tube is mandatory, as uh, it will avoid further mucosal as to be done, as it is a corrosive poisoning, and it has to be taken care that there should not be further injury. Try to place NG tube as early as possible. Avoid supplementary oxygen unless patient is significantly hypoxic, because oxygen itself enhances the paraquat toxicity, because it releases free radicals, oxygen free radicals. Oxygen supplementation will increase the free radical uh, concentration and further helps in the damage of the organs. So coming to the extracorporeal therapies, hemoperfusion is one of the thing indications within 4 hours of the ingestion. Usually, a rebound of plasma paraquat may be followed the hemoperfusion, so it can be continuous. Extracorporeal techniques have to taken till urine diathermate test is negative post 6 hours of the extracorporeal uh, uh, therapies. So one such cartridge is HA230 is used for the acute poisonings. The treatment within 4 hours will help you out in all the cases, but usually it is not possible in most of the cases, because we don't know the timing of ingestion or the late presentation. But it should be confirmed with the signs and symptoms of the uh, patient presentation prior to initiation. Usually, the expected and good outcomes are seen when there is no signs and symptoms at the time of presentation and within 4 hours. If already there are signs and symptoms, the prognosis is poor in spite of the extracorporeal therapies. Most of the literature what we have for the extracorporeal are from the non-English literature, mostly from the Chinese group, Chinese studies. So this is one of the study, that is early stage blood purification in paraquat poisoning, which is a multi-center retrospective study. They have done early hemoperfusion plus hemoperfusion with the continuous hemodiafiltrations after paraquat poisoning. They have said that there is a decrease in the paraquat levels, and they have improved in the organ failure and also survival. But there have been other extracorporeal therapies which have been used, like intermittent hemodialysis, hemofiltrations. These are also effective in enhancing the elimination of the uh, poison compared to that of a blood flows, because uh, comparable blood flows, you have to use a comparable blood flows for everything. That matters because it has a very low protein binding. So paraquat poisoning can be eliminated even with the hemodialysis. There has been a study showing that a concomitant perfusion and hemodialysis in patients with the acute pesticide poisoning, they have used concurrent and hemoperfusion followed by hemodialysis. The mortality was very high in the patient who has undergone hemoperfusion followed by hemodialysis comparative to concurrent hemoperfusion and hemodialysis. So, and during their multi-center logistic analysis, they got to know that age, ingestion volume, and presentation, and concurrent hemoperfusion and for with the hemodialysis have higher have been indicating the mortality. Usually, hemoperfusion followed by hemodialysis will causes higher mortality comparative to concurrent thing. So, concurrent hemoperfusion and hemodialysis is effective and safe treatment for the patients with acute pesticide poisoning, especially the paraquat. One more therapy is the anti-inflammatory and immunosuppressive therapy. In these, they give a combination of, first is immunosuppressive therapy. They usually give a dexamethasone 8 mg intravenously, IV 8th hourly for the first 7 days. In case of severe poisoning, you have to give up to 5 weeks. Uh, but there are no studies about the immunosuppressive therapy which is showing the mortality benefit. Here, the anti-inflammatory plus immunosuppressive therapy, that is cyclophosphamide with glucocorticoids, have been tried, and one of the study, that is a meta-analysis done in 2021, it was published, and it was saying there is no benefit by giving a combination therapy, but people keep using the anti-inflammatory and anti-impressive therapy because there is a study showing that the meta-analysis only hemoperfusion plus hemodialysis, and a group with hemoperfusion plus concurrent hemoperfusion plus hemodialysis with other therapies. They have shown with the other therapy combination, there is a mortality benefit. That is the reason they usually give a combination. But independently, this meta-analysis is not showing any benefit. Other antioxidant therapies which have been used is acetylcysteine infusion, usually same that of the dose used for paracetamol poisoning. It has been used, and sodium salicylate, deferoxamine, vitamin C, and vitamin E. There are no fixed dosing protocols for these drugs, as there is no appropriate studies or randomized trials suggesting the dose. So, these antioxidant therapies have been suggested based on the animal studies because they have seen some mortality benefit in them. And as the toxicity and side effects with these antioxidants therapies are minimal comparative to the paraquat poisoning, expecting a benefit, these are the possible antioxidant therapies which can be given. So, medical management and versus palliative care. When to go for a palliative care? Because giving an aggressive management in a severe toxic patients is of no use because ultimately the mortality is very high. So, when you know that the swallowing I mean the ingested paraquat toxicity is more volume is more than 30, or in a mouthful or two mouthfuls of a very high concentrated from 20 to 24% of paraquat poisoning, it is usually lethal. Or at the time of presentation, if you find a systemic toxicity effects, that is like patient is hypoxic, hypotensive, tachypnic, then the chances of having very prognosis will be there. So aggressive and invasive therapies in intensive care are unlikely to improve the outcome. So we need to talk with the relatives and try to assist him to accept the outcomes, because these are not helping out in the patient by doing any kind of aggressive management. Before that, we need to know, have an evidence clinically and biochemically that there is a severe toxicity before informing the attenders, and you need to continue supportive care. Intensive care should be avoided. You need to give only a supportive care in these kind of patients. So severe poisoning patients will have systemic toxicity at the time of presentation, that is tachypnea, hypoxia on room air. They'll have hypotension in spite of fluid resuscitation. They'll have a distributive shock and also a cardiogenic shock in these patients because of the myocarditis related. And they will have an evidence, clinically evidence of mediastinitis, pneumomediastinum, pneumothorax are very poor predictors of they are very high predictors of poor outcomes. And other signs of high mortality are severe acidosis at the time of presentation, hypoxia, and there should be a rapid decline in the renal function. Rapid decline means more than uh, 0.04 mg per deciliter within 1 hour, or more than 4.5 mg per deciliter in more than 4 hours. If there is an increase in the serum creatinine level, that means that the prognosis is very bad, and normogams can be used in determining the prognosis. So other routes of exposure are possibly skin, because during spraying and during using the pesticide, they might have chances of getting exposed. But usually intact skin is a effective barrier in a paraquat absorption and any normal absorption. Usually we see paraquat getting exposed to the exposed skin, like damaged skin, then there is a chances of absorption. Even if there is a absorption, it is usually with a very higher concentration, that is more than 20% of paraquat poisoning and exposure. And local effects, what we see depends upon the concentration of the formulation. The higher the concentration, the more will be irritation, blisters, and potentially full thickening burns can be developed from 1 to 3 days after the exposure. Systemic toxicity with an intact skin is very rare. uh, Patients have an exposure to the ice, especially during sprays. They will have a transient tingling sensation and will not cause any damage. But when there is a concentrated formulation which got exposed to the eyes, there might be a chances of severe inflammation of cornea, conjunctiva, and usually they develop within 24 hours of the exposure. And loss of cornea, conjunctival epithelium, iritis is a possibility, and these might lead to the secondary infections, and there might be a residual corneal scarring in these patients. Corneal edema, if at all, if it is present, it will persist for 3 to 4 weeks, and there will be chances of temporary blurring. In these patients, the eyes should be irrigated continuously with NS for 15 minutes, NS or either with the water, followed by slit lamp examination has to be seen to see the extent of damage. And local antibiotics are given, that is, eye drops are to be given to prevent for secondary infections. Always, if there is a concentrated solution splashed on the splashed onto the eyes, then you always have to, even at the time of presentation, if there is no tingling sensation or inflammation, the patient has to be reviewed after 24 hours. So inhalation, when it comes to inhalation, it's a paraquat is a non-volatile. Usually it causes a uh, nausea and headaches. Spraying, usually the droplets are very large, cannot be inhaled through lungs. But a fine mist, there is a possibility that upper respiratory tract exposure will be there. Even with the upper respiratory tract exposure, they'll cause a minimal um, irritation in the local area. And contact of nasal mucosa with fingers contaminated paraquat poisoning, there is a possibility of epistaxis in these patients. So overall, to summarize that fatality is present despite of treatment. Always supportive care is mainstay of the treatment. If the patient has come to the ER before symptoms onset and within 4 hours of the injection, extracorporeal therapy have been shown promising results. Prevention and education of the agriculture in the agriculture settings are mainstay because it prevents ingestion, and restricting and banning the paraquat poisoning is helpful in these patients. Thank you. And the prognosis, before that, I just wanted to know prognosis in if the patient has an acute hepatic injury and pancreatitis occurring, this will not have any prognosticating influence. It is only the hypoxia, myocarditis, and AKA that will give you a bad prognosis, but not hepatic injury and pancreatitis. Diquat poisoning is almost similar to that of treatment wise, similar to that of paraquat poisoning, but you do not, once the patient has survived the acute ingestion at that point of time in diquat poisoning, the long term sequelae or delayed progression of toxicity or respiratory failure will not be there in the diquat poisoning, which is a possibility in the paraquat poisoning. Thank you.
Thank you, Teja. I think it was a very comprehensive and crisp review of Paraquat, which is a current problem in especially in tier two cities where the facilities to diagnose and manage this poisoning are not easily available. Ghanshyam, you want to add something?
Just a couple of points, Teja.
Yes, sir.
Fantastic presentation. See, one of the major limitations that we currently have with Paraquat is our ability to quantify the toxicity. We rely heavily on the urine dithylamide test, but that's a qualitative test. You all should remember that it's a qualitative test. It doesn't actually give us the serum levels. Sometimes if you do not do the test properly, if the dilutions are not done properly, then there is a potential that you may either the results may be not truly reflecting of the serum levels. The second thing is, I think there are a few centers where people have used ECMOs as a bridge to transplant, but that's a very uh, may not
There
may
are
not happen.
Yes, sir. There are
Yes,
studies
Teja.
saying that ECMO, even if you put it as a bridging for the transplant, minimum
Yes.
32 weeks of time has to be taken because that is the minimum time period for the paraquat. If you transplant before that, there are chances that the transplanted organ will have a paraquat toxicity and leading to fibrosis in the later days, weeks.
Okay.
So minimum period should be a 32 weeks.
Okay. Thank you, Teja.
Yes.
Okay.
Thank you, sir.
Thank you, Teja. Thank you, Ghanshyam, for that opinion. I think it's a poisoning which is now going to dominate. We now know how early to intervene in organophosphate poisoning. Most centers know how to give PAM, when not to give PAM. So that mortality has reasonably come down in the country. But Paraquat, unfortunately, is a big problem. And what we may also need to remember is, being an agrarian economy, we depend largely on such less expensive weedicides. And we cannot completely ban it. Sri Lanka has had some success in regulating the use of paraquat by minimizing the amount of paraquat which can be sold to a particular individual based on the acreage of cultivation he's doing. I think that is something which we can do. If the human lethal dose is 30 ml, I think for 1 acre, it is less than 10 ml that is required for somebody. So we don't know whether such kind of regulation is possible in our kind of political scenario, but that's one option. But I think it's an expensive poisoning compared to organophosphate. And I think as more and more evidence emerges, there will definitely be different phenotypes of paraquat poisoning. We'll have to wait and watch, but it was an excellent presentation. If any of you have any queries or comments on this presentation, please post them on the group from where you got this link from, and the moderator or the speaker or both will try to answer them as soon as possible. Thank you very much, all of you. Have a good day.
Thank you,
Enjoy the
sir.
rest of Diwali. Bye bye.
Thank you, sir. Thank you.
Right. Thank you.
Thank you.
Thank you, Teja.
Thank you, sir.